Okay, good afternoon, everyone, and thank you again for joining to one of the talk before last of the year. And my name is, for those who don't know me, my name is Angela Jiang Wan. I'm a postdoctoral fellow at the Center for Social Norms and Behavioral Dynamics at the University of Pennsylvania. And just for you to know, this seminar will be recorded and we will upload the video to our YouTube channel and website. So moving to today's agenda, we have two very compelling talks for you, starting with a brief talk by an early career researcher, Marcelo Wu from the University of Nottingham, followed by the main talk by Silvia Saccardo from Carnegie Mellon University. And after these talks, we will have a brief Q&A segment open to all participants towards the end. For anyone who may be new to this series, the NoBec talks are organized by the Center for Social Norms and Behavioral Dynamics here at Penn, with the support of the Philosophy, Politics, and Economics program, and in partnership with the Master of Behavioral and Decision Sciences program. The center itself is a research center which provides specialized consulting, research, and training services to organizations throughout the world seeking to enact positive behavioral change. And here you can see the schedule of our upcoming NoBec talks. You can register for these talks as always on your website or scan the QR code right here. We publish the titles and abstracts about 1 week before each talk on our website and in our newsletter. And you can also sign up to receive updates about future talks in the QR code. As you can see, in June, we will have the last talk of this academic year. We will take a break for the summer and then we will restart again in September. So lastly, before we turn to our speakers, I would like to just point a few ground rules. You should be automatically muted when entering the call, but if you are not, please kindly mute yourself. And if possible, please keep your camera on so we can have a more interactive discussion. For questions, you can use the chat at any time, or you can use the raise hand function at the very end of the session. And the recordings of the sessions, as I told you before, will be uploaded to our website and YouTube channel. So our first presentation today is by an early career researcher, Marcelo Wu. Marcelo Wu is a PhD economist from the University of Nottingham, affiliated with the Center for Decision Research and Experimental Economics, also known as TEDx. His research focuses on how individuals process information, form beliefs, and make decisions, with a particular emphasis on the economic consequences of non-standard belief updating. He combines theory and empirical methods, and his work has been published in the Journal of Economic Behavior and Organization. His research lies at the intersection of behavioral economics and applied microeconomics, with applications to discrimination in the labor market and decision-making in organizations. Marcelo's presentation today is on Heads in the Sand, Theory and Experiment on the Interdependence of Information Avoidance. Before we move to the talk, I just wanted to remind you that if any questions come up during the presentation, please feel free to put them in the chat. So now I will stop sharing my screen so you can present. Marcelo, go ahead and thank you very much again.
Thank you very much. So now you should be able to see my slides. Perfect. Okay, hi everyone. Thank you very much for having me here. I will present Heads in the Sand. This is joint work with Silvia and Fabio Tofano. The motivation of this paper is that information is often widely and freely available, easy to process, and it also improves decisions. However, it has been documented that in many cases, even in those ideal situations, people choose not to know. This behavior is called information avoidance and has been documented in a variety of domains including health, finance, and climate. One may wonder why people would throw away valuable information. And one motive that has been identified is that bad news about the state of health, finance, and climate can induce unpleasant emotions. Just to give you a few examples, in 2020, there was this survey by Pew Research Center that found that 43% of US adults reported that interacting with news about the COVID outbreak made them feel worse emotionally. And more recently, when people think about climate news, they experience frustration, sadness, anxiety, guilt, and annoyance. So this type of negative emotions can be one reason why people disengage with information. Now, the literature on information avoidance mostly focuses on individual decision settings, where individuals are basically isolated from each other. However, in reality, individual outcomes often depend on others' decisions. Think about global warming, pandemics, and organizational performance. In such settings, there may be an externality associated to information decisions. If I avoid news about, say, global warming, that will lead to inaction, and that will worsen the outcomes for everyone if things are bad. So given this externality, if I believe that many others are uninformed and that hence are doing basically nothing about the potential problem, the outcome becomes worse. And then learning news about global warming becomes scarier and entails worse emotions, which means that this can introduce stronger incentives to avoid information. So therefore, there is the risk that ignorance can become contagious in a group. And this is a theoretical hypothesis that Benabou has published in a theoretical paper on group thinking. What we do in this paper, we study information avoidance in groups with externalities. And our research question is, do people exhibit this kind of contagious ignorance or complementarity in information avoidance? And is the opposite tendency, substitutability, also a possibility? This paper, to the best of our knowledge, is the first experimental evidence on this question. On the theoretical side, we show that these heterogeneous responses are possible. Some people may exhibit complementarity, but also substitutability. We design an experiment to document this heterogeneity. And then we do some simulations to show how the composition of types in a group maps into the equilibrium levels of ignorance. And we find nonlinearities and tipping points. So on the theoretical side, we assume that people experience emotions or anticipatory utility from anticipating future outcomes. And that is encapsulated on an anticipatory utility function. And we show that depending on the shape of the anticipatory utility function, 4 types of best responses or strategy types are possible. On the one hand, we can have strategic complementarity, as in Benabou. For these types of agents, they will optimally avoid information only when many people avoid information in their group, but get information otherwise. But we may have the opposite pattern, which is strategic substitutability, where people get information when many people avoid information. To give you an intuition, this can happen when the anticipatory utility function has reference dependencies. So when things are very bad because many other people are avoiding information, we are below the reference point. And in this point, if one obtains information and finds out good news, the upside in utility is relatively large, but the downside of finding out bad news is relatively small. So here, one may prefer to obtain information. But on the other side, above the reference point, the opposite can happen, giving rise to substitutability. So we can have these 4 types of strategic interdependence, and we design an experiment to measure this. The experimental design is based on a design by Falk and Zimmerman, who study information avoidance in individuals, but we extend this to group decision-making with externalities. So at the start of the experiment, subjects are matched into groups, and they are told that at the end of the experiment, the group will experience some event. This event is common to the group and depends on a randomly drawn state of the world. There are 2 states, a bad state and a good state. In the bad state, the group will have to listen to aversive noises at unpredictable times during these 4 minutes. In the good state, there will be no noises. At some point before, people will have to decide whether to get information about the state of the world. So we offer them the possibility of learning the state of the world, meaning what will happen in the future at no monetary cost, or just avoid this information. We elicit a conditional choice and unconditional choices for all participants using the strategy method. And we introduce an externality associated to the information decision. The information acquisition will mitigate the severity of the bad state. More particularly, each informed member will lower the volume of the noises by a fixed amount for everyone. So from the strategy method, we can elicit the best response schedules for each individual. And this is the distribution of strategy types that we find in the experiment. So the model type is always getters. Those are people who prefer to get informed, independently of what others do. Those are 42%. But then importantly, we find evidence of strategic complementarity, 20% of the sample. Those are individuals who are contagious. And then we find a similar share of strategic substitutes who exhibit the opposite pattern. And then we have about 10% of always avoiders. And then we look at what type of responses these people generate. So what we do is we can subset the sample by each type. We can collect the individual best responses, and we can construct the average group level best responses. So this is how the group level best response schedules look like. So the strategic complements have a positive sloped schedule, and the strategic substitutes have a negatively sloped schedule. And this schedule determines responses to information interventions shifting empirical expectations. We can think of interventions shifting empirical expectations as moving beliefs on the x-axis, and the blue line tells us what the best response of the group will be. So for strategic complements, reducing expectations will reduce the percentage of people who optimally avoid information, but for strategic substitutes, it will increase it. We can also find what are the equilibria of this group by finding the fixed points of these schedules. And we find that for complements, we have three equilibria, multiple equilibria, one where everybody gets informed, one where everybody remains ignorant, and one interior equilibrium. And because in reality, we don't have just groups composed by a single type, but a mixture, what we do next is a simulation exercise where we combine different types, and we see how the equilibrium responses respond to different compositions, group compositions. 100% complements, and we will gradually add always getters to this group. So that sequence is on the x-axis, where we progressively add always avoiders to the group. And then within each composition, we bootstrap sample groups and derive the equilibria of the group. So the points, the gray points, are the equilibria found in each of the simulations. So we have for each composition, we have a distribution of equilibrium points, and we can the solid lines tells us the features of the summary statistics of the distribution. So for example, if we take the median, when we have a 10% participation of always avoiders, the median equilibrium is at 20, is one where 20% of people avoid information. But as soon as we add just 10% more always avoiders, the median equilibrium jumps to 100%. So the pattern that emerges is that the equilibrium responses to changes in group composition are monotonic and nonlinear, and there are tipping points where small compositional changes can trigger large responses of equilibrium. There's a little bit more in the paper that I don't have time to talk about. We have treatments shifting empirical expectations. We find that on average, ignorance is contagious. And we talk about mechanisms, in particular the role of anticipatory utility, and then also the role of social preferences, given that this is a setting with externalities. So to summarize, we provide the first experimental evidence on the social interdependence of information avoidance when in a setting where ignorance imposes a negative externality. The best responses to others' informational choices are substantially heterogeneous. We find empirical evidence of 4 strategic types, and the composition of types matters for the equilibrium prevalence of ignorance. This relationship is monotonic and nonlinear with tipping points. And one takeaway for policy is that incentive for information take-up should take into account its social interdependencies. Thank you very much.
Thank you, Marcelo, a lot for the fantastic presentation. We don't have time right now to take questions, so I will have to move on directly to the main speaker's talk. But as a reminder, if you have questions for Marcelo, please put them in the chat and Marcelo can reply to them through the session or at the end in the Q&A. So I will share my screen again. Okay. So moving on, today's main talk will be by Silvia Saccardo. Silvia Saccardo is an associate professor of social and decision sciences at Carnegie Mellon University. And as a behavioral economist, she studies how financial and psychological motives shape beliefs, information seeking, and decision making, with implications for organizational design and public policy. Her work leverages lab, online, and field experiments to provide both theoretical and practical insights in areas such as moral behavior, health, education, and gender equity in the workplace. Recently, she has focused on developing a nuanced understanding of the factors that favor or hinder the scalability of behavioral science findings, and her work has been published in leading journals such as American Economic Review, Journal of Political Economy, Nature, PNAS, Nature Human Behavior, Management Science, and JAMA, and has been funded by both federal agencies and private foundations. Silvia serves as an associate editor at Management Science, has organized leading behavioral economics and behavioral science conferences, and has advised several organizations on leveraging behavioral insights. And Silvia's talk today is on selective inattention, evidence from healthcare. So Silvia, I will stop sharing my screen now so you can begin sharing your presentation. Thank you again very much for joining us today.
All right, thank you very much. Am I sharing correctly? All right. Thank you so much for having me. I'm very excited today to tell you about this work. Our working title is Selective Inattention, Evidence from Healthcare. I want to say the Marcelo's talk was a great prequel to the overall topic of this project, though this is a more applied project. So let me dive in. I wanted to start with a quote by Herb Simon, something Herb Simon wrote in 1971, which is a wealth of information creates a poverty of attention, right? So this line was written before smartphone, before group chats, before social media and all of that, but it feels even more true today. It's very current, and psychologists and economists have long recognized the importance of attention and the fact that attention is not unlimited. It's a scarce cognitive resource, and in today information-rich environments, individuals cannot really process all available information. Attention is selectively directed across competing stimuli. This is true in every domain. The domain I will focus on is healthcare, where attention is very critical. In fact, in healthcare, attention can be a bottleneck for many outcomes. Think about everything patients. So let's focus on patients because this will be the focus of the talk. Think about everything patients nowadays are asked to do, like track lab results, open portal messaging, schedule screening, take medications on time, get vaccinated, follow up on specialist referrals. Every one of those actions start with attention. You need to devote attention to those things, and then this is necessary for them to take action. And so one natural question is, how do we direct patient attention in healthcare to consequential activity? This is a very important question in the healthcare domain. And so let's start from what drives attention. So there are decades of research in cognitive psychology and neuroscience that distinguish two broad mechanisms of attention. The first mechanism is bottom-up or stimulus-driven. So according to this work, attention is captured more or less it's triggered automatically by stimuli that appear in the environment, right? Regardless of what people are trying to focus on at a given moment. So imagine right now, as I'm talking, a notification pops up, right, on the corner of your screen, and this might steer your attention to that, right? So that's bottom-up attention at work. So one powerful way to leverage this mechanism for behavior change research is reminders, right? Through reminders are really bottom up, might make an action item suddenly salient. And capturing attention, and there has been a lot of work on leveraging reminders for behavior change. Some of this work on my own that I'll show you here, which I have done in collaboration with Heng Chen Dang, with a co-author and a partner in crime of everything I'm gonna present today. So Heng Chen and I have done like some studies that use reminders in the healthcare context to promote like behavior change. One was in collaboration with the Behavior Change for Good initiative led by Katie Milkman and Angela Duckworth, where we tested the impact of reminders in the context of promoting flu vaccination and found reminders can be very effective. Another one that we have done was in the context of COVID-19 vaccination. Whenever the first dose of the vaccine became available, we partnered with a large healthcare provider in California, UCLA Health, who will be the partner of in our experiments today, and tested the impact of reminders in the context of encouraging the first dose of COVID vaccine, and found reminders can really help and increase vaccination. And then we also looked at reminders in the context of promoting COVID boosters, like over a year after people had taken the first dose, to test like, okay, one reminder helps, can more reminder help? And we found, yes, reminders can really help. So we see there is some evidence, and there is a lot of other research that I'm not putting here, testing the impact of reminders in a variety of domains that find, okay, this bottom-up approach can, bottom-up approach can really help. However, if you think about healthcare today, reminders are everywhere. Patients, and now I'll show you like over the course of 2 weeks, like patients can be flooded with so many messages, like this example that you see now on the screen are messages that I or my collaborators got. Patients are flooded with messages, important emails, app notification from clinics, pharmacies, insurance, digital health platform. And in this noise, even critical messages, the important messages, might get overlooked, right? And this brings me to the second important mechanism of attention. Attention is also top-down or goal-directed. Because we cannot process everything, we tend to prioritize what matters, right? We deliberately allocate attention to where the information we believe is consequential, to issues with higher perceived value, right? Economics formalizes this in model of rational inattentions, where agents optimally allocate attention based on the expected value of information. In psychology, there is research on goal-directed attention, that also suggests, individuals tend to redirect attention to things that are important. And this raises a natural question, which is important for this project. If people prioritize attention to information with higher expected value, can messages designed to raise the perceived value of information boost engagement? And this is sort of the central question that motivated this project. In particular, in this project, what we do is ask, do messages designed to raise the perceived value of attending to health information increase patient engagement with that information? We do this in the field, though I will also show some companion online studies, in the context of preventive health screening, right? Preventive health, it's an important context where we want patients to pay attention. What we do here, I'll present today some pre-registered randomized controlled trials that we ran in collaboration with our partner, UCLA Health. And then, as I said, some companion online studies. Okay, so what is the goal that we do? So we are trying to raise the value of attending to screening information. So naturally, in the space of preventive care, one intuitive approach that healthcare providers already engage on to engage people is telling people about the risk or severity of a particular disease the screening is trying to catch, right? So this, for example, is a message I received from a healthcare provider in Pittsburgh. Heart disease is the leading cause of death in the United States. And then this was followed by a invitation to schedule like a health check. Or this other one death every 33 seconds, like heart disease is the leading cause of death in the United States, schedule an appointment. This is from a different healthcare provider. So if patients understand the idea behind this is if patients really understand the stakes, they might attend and engage to this information more and engage with it more and maybe eventually do the screening. So one approach we thought of is, okay, what if we provide patients with information about the risk of severity of a disease? These should increase attention to screening information in line with, models of rational attention, in like also with psychological research on fear appeals that has found in online, like hypothetical studies like that, some make increasing the stake with these fear appeals might increase intention to take on a particular screening, and also research on risk appraisal as a behavior change lever. So we try to do this in the field. And our field context is in the context of colorectal cancer screening. Colorectal cancer is the second leading cause of a cancer-related death in the US, and early detection is shown to reduce mortality. We were able to run an RCT when in 2021, the National Screening Guidelines changed the recommendation and decrease the age where colorectal cancer screening should begin from age 50 to age 45 due to the high incidence of colorectal cancer incidence in younger population. So at the time when the recommendation changed, our partner organization wanted to notify all adults age 45 to 50 that now they needed to get screened. And we were able to run an RCT whenever that happened. In particular, what we did is our sample as 20,000, average risk individuals, age 45 to 49, who became eligible at that time. Okay. And the setup is that, so the hospital really wanted to notify these people, and as they have seen our research, we are collaborating on this COVID research, so they saw reminders was a good approach and wanted to send reminders to all these adults, encouraging them to get screened. Our participants or the patients in this RCT were randomized, where all receive a reminder. In the past, we studied like the impact of reminders compared to not receiving a reminder. Here, we are like randomizing everybody to receive a reminder. But in the control condition, people receive just a basic reminder saying, you have a message from your doctor about colorectal cancer screening. Click here to read how to get screened. So this message is simple message, mentions cancer, tells people read here how to get screened. In the risk message, we wanted to increase the stakes, right? And we did that by highlighting the risk. The message said, doctors have recently found that younger people like you, age 45, 49, are at increased risk for colorectal cancer and need to be screened. Click here to read a message from your doctor on how to get screened. So this message basically tells the patients, the participants, that they are at increased risk. And ideally, like we expected, okay, so this should attract more attention because it's more important, and so on. Before I show you the results, we ran some prediction studies, both with lay people and physicians, to see what people thought about these messages. So first, we recruited people from cloud research. We showed them the two messages and asked which message is expected to attract more attention. This was our DV. And what we see is that more like the majority expected expected the risk message to attract more attention. Then we moved to a sample of healthcare professionals. And to them, we recruited them at a symposium at UCLA Health. It's a small sample, it's 62 attendees of this symposium. We show the two messages and ask which message is expected to drive more clicks. So we're here, we really ask them like, where do you think people will click more, right? And again, the risk message was expected to have more clicks. Finally, we recruited PCP, primary care physicians. Those are people that deal with patients every day. And so they might know best how to engage them and how to communicate the importance of doing preventive care screening. We showed them again the two messages. And again, even in this sample of physicians, the majority expected the risk message to drive more clicks, to get patients more engaged. What do we find in the field? So we ran this again with 20,000 people, randomized to the messages. And what we find is that the risk messages actually, there is a large decrease, or a 7 percentage point decrease in clicks when we move from the control message to the risk message. So we get people less engaged with this message. These odds when controlling for all the pre-registered controls like age, sex, race, social vulnerability index, patient portal login. So it's pretty robust. One question you might ask is, what happens if the message, so the message itself like communicates risk, but doesn't say anything about like, oh, it's very easy to get screened. And there is some research in psychology that suggests that efficacy statement, both in terms of self-efficacy, like telling people like, you can do it, but also in terms of like the action is desirable and it's easy to do, can strengthen the impact of a fear-based appeal. So like can get people more to respond more. And so we had a third condition that added just a simple statement to the basic risk message, like an action message that said, a 3-minute effort today could help save your life. This message was predicted to be more effective than control by 66% of UCLA physicians in our sample. But yes, it does increase engagement, so click by about 1%, by about 1 percentage point, but there is still the large negative effect. So it doesn't overcome this large negative effect of communicating the risk information. Now, this DV is just whether people click within 1 week of receiving the text message, which was our primary pre-registered outcome. I have some other work that looks like, okay, do results hold whenever we look at larger time windows? Maybe people are like just slower to click, but these holds, like the graph looks basically the same. I didn't paste it here because you don't even see the slide advancing when we look at click rates within 1 month. So just to summarize so far, like this message designed to capture attention really like had this negative effect and expected to capture attention both by lay participants and by healthcare professionals and primary care physicians, really has this a large negative effect on patient engagement. So why did this message backfire? Well, a growing line of work argues that, attention itself can have utility consequences. Attending to information is not like a neutral cognitive act. It could evoke feelings, right? And some of these feelings might be negative. And so this might lead people to want to disengage. If engaging with information, in fact, is expected to be unpleasant, there is work suggesting that individual might avoid attending to it and engaging with it, very consistent with work on information avoidance, where individuals avoid threatening information. We saw Marcelo already discuss this work in the domain of like individuals declining to take screenings or learning test results, potentially because of the negative, worried about the receiving negative news. So one hypothesis is that this same mechanism could affect engagement with the health. That's one step even before getting the screening, like just engagement with this health information. And so particularly we hypothesize like, okay, there might be willful inattention, like highlighting the value of screening with risk information might draw attention to the possibility of bad outcome, something emotionally unpleasant to focus on, which might in turn lead individuals to avoid engaging with the message altogether. We can't go back to the field, but to really test this hypothesis. But one thing that we did is we have these text messages, and so one thing we do is go online and run an online study that shows these messages to people. This study asks the question, does the risk message direct attention to the potential for negative news? In particular, what do? We recruit about 2,000 prolific and connect participants of the same age of our sample, just to increase, like, realism, like make it as similar as possible to the original population. We ask individuals to imagine receiving a text message for their healthcare provider. Now, I want to say this study is not incentive compatible, it's an hypothetical, just because we can't get people to engage with screening in the online sample. But there is work suggesting that those studies still are informative, and in this particular context, we want to see exactly what the message does, right? How people evaluate the message. So in this sample, what we do is we have people randomized to see either the control message or the risk message. And then what we measure is first that we have a scale that measures value of clicking on the link and learning about this screening. We ask questions like, this screening is important, like this. Does this increase the stakes? That's basically the question. Learning about this screening feels critical to my well-being. It's important for people like me to learn about this screening. We also measure whether people expect negative news. This type of message increases the expected and anticipated negative valence of potential information people might find out. Something like learning about this screening could bring up uncomfortable thoughts, might direct my attention to things I prefer not to think about, makes me feel at higher risk of receiving bad or upsetting news. This scale, like all the items load on the same factor and they're highly correlated. So we aggregate it in one composite. What do we find? So this graph shows the treatment effects on attention-related measure. So like relative to control, the difference between the risk message and the control message, we see that the risk message directionally, but not significantly increase this perceived value, like the importance scale. But what it does, it significantly increase this anticipated negative valence score or index, right? Suggesting that people who see the risk message are more likely to think about the potential for negative news. We also ask hypothetically, like, would you click on this message? Here it's directional. We see that directionally, we see the control, like we see the same directional backfiring effect of the risk message by about 4 percentage points, but not statistically significant. As you can see, a p-value of 0.10. Which could be the hypothetical nature of the study. But one takeaway from this study is that really the message does increase the negative thoughts, potential, like this anticipated negative valence index. As part of the study, we also measure other things that the message might potentially change. For example, this message, people might think the message is irrelevant to them, doesn't apply to them, even though they are 45 to 49 years old at a higher risk. People might think, it's not me. We also measure this information is not believable. Also things like, I think my healthcare provider is trying to restrict my choice by things that the message might change. We don't see much action on those items. And in fact, this is just correlational evidence, but if we put everything into a mediation model, what we see is that the risk increases this negative valence, which then decreases as a negative indirect effect. We see this indirect effect via negative valence on click, and we don't see it for the other variable. But take this with a grain of salt, because this is just correlational analysis. Okay. So one takeaway from this study is that really this message does increase the anticipated negative valence of information. Whenever we were presenting this work, in one seminar, I was told, like, well, the message is also longer, right? So it could be that it's just a fluency story, right? Like people are like, see this longer message, it's harder to process and all of that. So still in these hypothetical online studies, we ask the question, does this risk message harm fluency? So we show people like either the basic message or the risk message, which you can see is longer, right? We were also, another feedback we got is like, oh, people maybe in the control, they see the link right away. In the risk, it's so long that they won't get to the link and they won't click. So we have a version where the link, we were suggested to do this, like a version where the link is sooner. And then just measure like fluency. Do people like find this message easier to read, easier to process, and also using a fluency scale. And then we also measure content recall, right? Maybe like people don't, in one, they just focus on risk and they don't remember that they don't process that they have to click on the link and go to read this information about how to get screened. So we have like a multiple choice answer. What did the message ask you to do? Just in a nutshell, we do not see differences, at least in this online study. The field, of course, could still be different, but in a highly controlled lab experiment online, we don't see differences in perceived fluency of these messages. We also don't see differences in the recall of the call to action of people noticing the link in this recall measure. We also look at open-ended response, and in the open-ended response, we see that in the risk condition, people correctly remember that there is a, the risk point, but they're not less likely to remember that there is this call of action. Okay, so this is just hypothetical evidence. So what about the field data? Is the field data consistent with willful inattention? Obviously, that study was done and we couldn't do more with the data, but one thing we could do is if willful inattention is true, we might expect people who are more worried about negative health news to show a bigger effect. Because if you are more worried than others, no, ideally, if I was in the lab, I would have measured this and then do an heterogeneity by worry. We don't have that in the field. One piece of information we could get from the hospital, though, is whether people have family members with an history of colorectal cancer screening. And we can do an heterogeneity by that. Now, I want to say this is like an exploratory analysis, so take it with a grain of salt. But what do we find when we split by whether patients have a family history of colon cancer? What we find, so first of all, this is just like without family history, we see that the risk information, like we see this negative effect. What about patients with family history? Now, there is work suggesting, like in medicine, suggesting that people with family history actually are more likely to engage in these screenings. And we see this in the control condition. When people get the control message and they have a family history, they are like much more likely to click. One thing I want to point out, it's a very small, so take it really with a grain of salt. It's very small sample size. But what we see is that, so there is this they are more likely to engage in the control condition, but as soon as we have the risk message, they are not, right? And the interaction here is statistically significant such that the negative effect of the risk information is larger in the risk condition. Okay. More on the field data. Is this field data really consistent? There could be other alternative explanations. Another alternative explanation is that maybe patients find the information in the message, the risk message, so important that they're not even clicking on the link. They go directly to the portal, right? And we are actually prompting them to take action right away. And so we don't see this in the link, in the clicking on the link. But then we can look at the portal. So we got from the hospital, like the portal. So whenever patients arrived to the portal, there was a letter for them explaining how to get screened. And if this alternative explanation is true, then we will see people who don't click to be more likely to read the letter, right? Because they just go right away. We can look at that. So whenever if people clicked on the link or not, they could log into the portal and read this letter from their doctor that explained how to get screened, either with the FIT kit, which is a fecal exam, or with colonoscopy. So what happens with for people who don't click? Again, the hypothesis is that if they find it even more important, they bypass the clicks. We don't see it in the click, but we will see it in the letter. They will be more likely to read the letter, but we don't see that. So this graph shows like 1 month after the intervention, the effect of the intervention on reading the letter. And we still see this negative effect. This is just on non-clickers, people who don't click. So we don't find evidence for this alternative explanation. We see actually that there is a negative effect of the risk treatment for non-clickers. We see it also among people who actually click the link. People who click on the link are still less likely to read the letter whenever they are in the risk condition, like sort of like here significantly so, here no. But when we put everything together and we look at the intent to treat on reading, we can look at the impact of the intervention on reading rates directly over here, and we still see that we have a negative effect of the intervention on reading by 7 percentage points. So this rules out. It's not that people find it that it's so important that they bypass the text message, they don't click on the text message, they go directly to the portal. The next question you might ask is that is there an impact on screening rates? The impact on screening rates, we see it's directional, it's suggestive. So I don't want to make any claim. We could access, so that's our pre-registered secondary DV, was screening rates 6 months after receiving this intervention. We see that overall, people in the risk and risk plus action condition are about 1 percentage point less likely to get screening, which is, it depends. It's marginally significant in some specific, I don't want to make big claims about that. There is a directional effect on actual screening 6 months down the line. The screening measure, it's a bit imprecise because if people I've scheduled a screening, but they haven't done it within 6 months, they appear as not screened. If they have fecal screening, but then it has inconclusive results, it's also coded by the hospital as non-screening. So it's a bit imprecise. We looked a little bit into different explanations. So why does the gap narrow? So is it just like we see a large 7 percentage point gap between control and the risk condition in the clicks and in reading rates? Why does it narrow for screening? Multiple explanations. One could be that simply reading doesn't guarantee action, right? So people might read, but then there might be other barriers to action. And in line with that, we see that only 30% of patients who read the letter within 1 month are actually then eventually screened. And these, if we look at the gap and multiply it by 30%, we see that this could explain part of why the gap narrows. However, there could be other things going on. Another reason for why the gap in screening might be reduced is that other type of outreach might reduce the gap. And here we could imperfectly, but test a little bit for this, because 25% of RCT patients in this sample were randomized to receive a default fit kit at home as part of a separate RCT that happened within this, like, just a few weeks later, after like this initial message. So 25% of the people received this default. We have a separate paper in JAMA about this, like looking at how default screening actually can increase screening rates. So just for the sake of this project, like 25% of the people receive this default. What happens if we exclude and look at the impact on screening for people who don't receive this default like screening method at home? It's still suggestive. Like we see that there is now the gap is like about 2 percentage points. It's more precise, but still like it's not consistent across conditions. So I don't want to again make big claims. So again, like it's plausible in theory. It could be part of why we don't see this large gap, but not super clear in the evidence. One last explanation is that, as I said earlier, treatment patients might find this risk message so important that they don't click on the message. They even bypass the screening and they directly call the hospital to schedule a colonoscopy or like schedule a screening. So could that be an alternative explanation, a reason for why we don't see the impact, such a large impact on screening? Not really. Only 10% of the people who don't read schedule a screening later on. So it's unlikely to explain the pattern. So we think like we see a large negative impact on engagement and reading rates. We see a smaller impact on screening, but it's 6 months down the road, potentially due to these first two explanations. Now, let me get back to attention. So the summary so far is that we raise the value, so our approach to raising the value to attending to health information is expected to work by lay people, by healthcare professionals, but it has unintended consequences in the field because it lowers the click rate and it lowers the reading of the letter on the patient portal, some weak evidence that it affects screening, as we just discussed. Online studies and additional field analysis do point in the direction of people potentially being worried about getting negative news, being less likely to screening, which is an explanation consistent with the idea of willful inattention. One other thing that we do in the paper is ask, is this just specific to risk? Or is it more broadly about getting people like raising importance, getting people worried about potential of negative news more broadly? In fact, if we look at many healthcare contexts, there are multiple ways in which hospitals tend to raise the value of attending to health information. One other approach that we see a lot is telling people about stories about other patients who, add, like just as a case example, as an example, patients who got screened, and because of that saved their life. So that sort of should increase the importance of doing this. We see this, UCLA Health had done it separately from us as a campaign in the domain of colorectal cancer. They had done this like testimonial for breast cancer, just like highlighting the positive impact of early detection by highlighting one patient case. So one approach we were able to test, because they were interested in that, is an alternative approach is really share the story of a real patient whose life was saved by the recommended activity, by the screening. And these should, again, help raise the perceived value of attending to health information, both in line of research, that this should also capture attention, both in line of research on the effectiveness of narratives in changing beliefs, research on the identifiable victim effects, as well as of research in the health context on the impact of patient testimonials or narratives as a persuasion tool. So all of this work should kind of suggest that this approach could be effective. We were able to test it with UCLA Health as part of a different campaign where patients with overdue preventive care received a patient letter highlighting all of the tests that they had to do. Like, so it could be also colon cancer, but also breast cancer, cervical cancer, diabetes management. So this is a campaign that the hospital does. And as part of this campaign, we were able to randomize patients who had not read the letter, so because the hospital knows whether patients read this letter, to receive reminders, to receive text messages highlighting the importance of going to the patient portal and read this letter about these health gaps, right? Like overdue screening and tests. So participants received different text reminders, and in the basic control, the reminder was something like that. 2 weeks ago, your care team identified a health gap on your record. Click here to close your gap. In the treatment, we had this life-saving story reminder, which included like the story of David Dillon, a UCLA patient who said promptly closing her health gap saved her life. This linked to an article that UCLA Health wrote about like colon cancer with the example of this patient who got screened and that helped saving her life. What does this message do? Does this work as a way to capture attention? We see that in the control conditions, 16% of the patients engage, click on the link. What about the story? Again, an unintended large negative effect on engaging with this message, clicking on the link. Next, we ask, okay, what is this drop due to? Is it the story format? So people might think like, oh, the story is like this patient, like whatever. I don't care about this one patient. It's irrelevant to me. So maybe it's just the story format that leads to the drop, and it's not the broader story about thinking about negative potential outcomes. Another alternative explanation is that the message, as I can show you here, included two links. And so people might click on one link with the story and not the link with the news article, and not the link to schedule the screening and read about the LCAPs. And so we ran a third RCT. We were able to partner with them again and run a third RCT that randomized people to 4 different text reminders now. 2 were just a replication, so the basic message and the story message that I just said. The third, to address the idea, oh, maybe this story is not relevant to the patient. And so we had like just a broader medical research has shown that promptly closing health gaps saves lives. So just like pointing out to the saving lives to raise importance. And then the third was a version of the story message that did not include the second link, but said everything in the text message. So our prompt action led to the early detection of colon cancer, which enables successful treatment, again, to raise the stakes over here. What do we find? So first of all, we replicate again this negative effect on engaging by just like raising the stakes by telling the story of the patient. Is it really about the story itself, or it's broader than that? It seems broader than that, because when it's like the life-saving scientific, it's also people are less likely to engage with the message as compared to the regular control. Was it the 2 links? Because the life-saving also had 2 links. Maybe part of the effects, whenever we include only 1 link, we see more people click, but there is still this large, like 6 percentage point negative impact on engaging with the health message. In the remaining 2 minutes, I'll be very quick. We do exactly what we did for the colon cancer screening exam to test the question. Let's go online, show people these messages, and ask whether the story increases, like directs people to the potential for negative news. So again, we did the same setup as before. We showed people the control reminder or the life-saving story reminder. And then we measured the perceived value of information as well as this anticipated negative valence. We also asked, hypothetically, would you click on the link? Again, as in the other RCT, we see that the message now increases. So this message is perceived like we are effectively like getting people to think the message is more important and clicking on the link is more important. But again, people expect more negative news when they see this story message. And this has an impact on clicking. When we look at open-ended, we ask people like, why didn't you click? And it's things like, it could reveal that I have a condition I'm not prepared for. I felt a wave of anxiety wash over me, and I did not expect ever to get good news. And when we aggregate them together, we see that more in the story, people are more worried about receiving negative news. I know I'm out of time, so quickly, the mediation results show is very similar as the other study. So I'll conclude here, like for in these takeaways across 3 RCTs that attempt to raise the perceived value of attending to health information. We see that these attempts backfire. We find some mechanisms, like one potential mechanism for this could be willful inattention. Intervention that make information harder to ignore can paradoxically make them more tempting to avoid. And effective intervention, therefore, must manage both the decision relevance, how important the information is, as well as the anticipated psychological cost of paying attention to the information. We're doing a lot, but I am running out of time. As a follow-up work, we're doing a lot of planned RCT to test boundary conditions, as well as how to fix. And we have partners, healthcare providers, both in China and in Chile, where we are like working actively in trying to better understand mechanism for the information avoidance and willful inattention. And with this, I want to thank the co-authors on this paper, my amazing PhD student co-authors, and other collaborators in part of the projects, as well as the funder. And now I'm ready to take questions. Thank you so much for your attention.
Thank you, Silvia. Thank you so much for the fantastic, very, very interesting talk. We have now time until 2:15, roughly, to take questions. I see we have also a queuing of questions in the chat, so maybe the way we can do this, I can alternate between taking questions by people who raise their hands and then alternate with questions in the chat so we can attend to everything. So first things first, Christina, please.
I think you're muted, Christina.
Christina, you are still muted.
Mute.
Perfect.
Okay, you hear me? Thank you so much. It's really interesting work. Now, let's go to the RCT1, which really piqued my attention, let's say. And the question you ask is, why so many clicks? Why so few clicks, in the very informative parts? But I would ask, why so many clicks in the control? And do you hear me? And I
Yes,
think,
I hear you. Sorry, I muted myself.
And the interesting question is, the control is very generic. And if I look at a control like that, I would be curious. I would click and see what follows. Okay? Yeah. So the curiosity, if you will, overwhelm other reasons, like fear, oh my God, he's talking about cancer, he's talking about this, he's talking about that, etc., etc. So I'm not denying that willful ignorance exists. Of course it does. But it seems to me that the fact that the message is so generic, it piques people's curiosity, overwhelming other reasons. And this may be the reason why I was asking myself, would I click? I would click the control.
You will click the control.
I would click the control. I would be very curious, but let's see what happens. In the other, you're already giving me information, and then you're already stimulating fear or whatever, other feelings I may have about that information.
Yeah, that's a great question. Our team, like with our collaborators, we thought a lot about curiosity as a potential alternative explanation, right? We actually, even more than this trial, we're like, here, we have a message from your doctor about colorectal cancer screening. Click here to read how to get screened. We thought like, we tried to make it less general as possible. The reason we don't test curiosity directly in this study. So the only way that I have now to go back is like do some sort of online studies like I did before, right? And which we could redo. Let me, so in this study in particular, we have not measured, like, sort of like this message does not seem relevant, does not apply, maybe might capture something, but it's not really directly measuring curiosity. We have done more with the other trial that I just showed you, but we could go back to this one as well. That's a very fair point. Over here, the control question, I feel it's even more generic because it might even more be more likely to trigger curiosity because of the health gap. There is an health gap. What's an health gap, right? Over here, we did a study where we tried to measure curiosity. We didn't see differences in that study. So that's my answer to you. But that said, like, it's a very well taken point. And if you have other recommendations on how to address it more, of course, because we would love to see, like, is this due to the control condition triggering curiosity as opposed to the message backfiring?
But you would have, to basically tailor a message. I am thinking also of global warming, of other issues, okay, that you give a specific message to people, they throw it away. And the question is, let's make them curious about that and how to do that. It's a difficult task. It's not easy. You have to know the psychology, et cetera, et cetera. But I think it may be an interesting avenue. That's it.
Thank you. Thank you so much.
Yes, I actually agree with Christina's comment. Now that when you show the screenshots again, I could see that in control you could see, just click to see what your doctor tells you, that your doctor has a message for you. But then in the risks message, you specifically say your doctor has a message for you about how to get screened. So it's true that now, like the second time, I actually realized there was a little
actually no. Actually, even the control message says, "Click here to read about how to get screened." So, like, we try to have it constant across both conditions. But yeah.
Yes, but I think that was a great comment, Christina. So now I'm gonna now jump to the chat. I see that Jonas had a question for Marcelo, but Marcelo just posted his reply. So I'm gonna jump to the next question. Eliza Johnson, you have a question. Would you like to just open your mic and maybe read it yourself?
Oh,
Eliza, are you here? Okay, otherwise, I can read it for you. So Eliza Johnson's comment is, in what environment were participants in when they saw the text message in online survey 1? Was it everyday life where attention is divided, or a dedicated time to review the message? And then she replies also, intention to respond was higher than the RCT, not the point of your talk, just something I noticed. And also recognize there are many other factors at play here, like self-bias, etc.
Yeah, that's a very fair. And my co-author and I have done a lot of separate work trying to really understand, like, why this in this online stuff. So, of course, this is an online environment where attention. I mean, these days people might be like doing so many different surveys at the same time, so we don't know. But you could, like, if people were giving undivided attention to our study, it's probably like a much more control, like high attention type of environment than that's what people experience in the field. And we actually think this is a reason for why, like, in our research, we have often seen some discrepancies between online and field because like this attention is different. We could try to do studies where like we distract people and it's like the same sort of like more similar to the environment in which people, but overall, even in these studies where people paid attention, we see like at least directionally that they're still less likely to click, even though they recall the message correctly. So suggesting that it's not just about these distractors in the environment.
Perfect. Thank you, Silvia. I see no one so far has raised their hand, so I'm just going to jump. The next question is from Christopher Santos Lang. Same as before, Christopher, if you're here with us, would you like to just open your
Sure.
mic and ask directly?
Yeah, so not everybody's at every session, right? So you may not have been here last week when Kyle Law, or last month when Kyle Law spoke about cognitive normative moral theory, which he implies that a good behavior is more positively judged when believing that it's rare. So, like if the message was from the doctor, I aim to help, but 80% of patients ignore messages from their doctors. Would you please at least click this link to review my recommendations and evidence behind it? Right? If people believe that it's rare to listen to their doctors, but their doctors should be paid attention to, then maybe they might, in that instance, be more likely to respond to that. That's what I think I get from Kyle's findings, which I think are supported. So it could be a great crossover between the different months, but it also relates to Marcelo's work, I think, about the idea that maybe some people in a group may be more inclined to pay attention to something if they believe that the other members of the group are not paying attention to it. And so it's their duty to sort of be the member of the group who does so. Does that make sense to you all?
Yeah, maybe Marcelo has some opinion on it, and feel free to weigh him. Yeah, that's a very interesting, like that could be an alternative way to capture patients' attention, right? Like not don't tell them like, okay, this is very important for you, but it's important. Like it could be that's a testable prediction. Could be interesting. We don't have data that could speak to that, I think, in our
Not yet,
current set of studies.
but if we can improve over the control, that's good for health.
Yeah, no, for sure.
Thank you, Christopher. Jana, would you like to speak?
Yep, thank you. I put my question in the chat, but we'll read it out. Hi, Silvia. Thanks so much for a fantastic talk. Really enjoyed it. I work in a setting where we do a lot of messaging to patients in relation to like polygenic risk score. So it's very, very relevant. I was curious about your thoughts about previous experience in this for this specific call to action. So I'm mindful because your sample targets people that previously weren't eligible for this screening, they arguably haven't gone through this type of screening before. So I'm curious if you have a sense of how previous experience with this type of screening would change perceptions to a risk message in the way that you've.
Yeah, that's super interesting. Yeah, it's true. Yeah, our sample was new to like it was the very, very first time they were newly eligible. I don't have data to speak to the question like, okay, is this just a novel, like the risk when it's a new thing, is it perceived differently? In the story though, the study where we leverage the story, it's different. It's not risk information, so you might think it's different. Over there, those were patients with like those were a variety of different health tests, and people had experience. So we could do analysis and look at that. Now I don't have it in the back of my head. I don't know if we have ever looked at that, but we could. So thank you for your point. But it's not really about risk in that study. So I might not have evidence that speak directly to your question.
Well, thank you.
Thank you, Jana. So jumping again to the chat as I will be alternating, the next question in the chat is actually mine. I will say with the last RCT you presented, maybe my question did lose a little bit of relevance, but I think it's still interesting to ask. So I wrote this question about the first RCT because I found it really interesting that the risk message didn't significantly increase the perceived value of attending to this kind of messages compared to control. So I was thinking, could it be something also about the informational value of the message? So maybe like already by just thinking about the screening in control, maybe patients are already aware of the risks. Let's say in the life-saving treatment, maybe patients by just thinking about the screening and priming themselves to think about colorectal cancer, maybe they already know that the screening is life-saving, right? So I wonder if part of the reason is because the elaborated message, be it like risk or story message, it didn't really increase information value. So let's say that participants' beliefs were not really updated. So the only thing that was updated was their negative feelings and whether that could explain the effects versus, let's say, maybe a message in contrast that also maybe updates their negative feelings, but that also is actually informational and maybe actually updates also their beliefs somehow. What do you think on this?
Yeah, that's interesting. So in the in the second set of RCT with the story, we do see that the value is significantly higher for the story message. So your point, it's more for the first RCT, where we see it directionally, but I think the reason why I think the effect might be smaller than what we originally expected and were powered to detect is that the control message in that study already uses the word cancer. Like you have a message about cancer screening, and people especially in this online study, they react a lot to the word cancer. In fact, we are at the very top of the scale already. And so I also think it's potentially why we don't see this updating in beliefs, as you are saying. Like, I mean, we could run a larger and more with a larger sample, be more powered to detect smaller effects and see what we find. We don't have it, but that's very interesting. Thank you for pointing that out.
Thank you, Silvia. So we are almost out of time. Rachel, is your question quick?
Yes, it's quick, and it's kind of a follow-up to the previous question, which is, I feel like you could do more with the subsample of your population that has a family history.
Okay.
Maybe, as was suggested, they've had experience with the screening test. Maybe they're already getting regular screenings because even though they're in a younger age group because of the family history. Maybe this is less new information for them. I don't exactly know what you should do there, but I feel like that's kind of a unique sample, and you could get more out of isolating them and looking at their patterns specifically.
That's great comment. Super quick reply. One thing is this study only included average risk people, so people with so a lot of people were excluded, especially people who had undergone screening in the past because of their risk not being. So we cannot do exactly that, but I'll brainstorm. I think it's very valuable to think more about what to do. Thank you so much for the comment.
Great. Thank you so much, Silvia and Marcelo, for your talks today. We are now really, really out of time, so let me just quickly share my screen to close the talk today. So thank you everyone for participating in today's NoBec talk. Thank you again, Silvia and Marcelo, for your compelling presentations and contributions. And thank you everyone for your participation and questions. We had a really engaging talk today. That was great. So we look forward to everyone's participation in the next NoBec talk by Ernesto Reuben in June 18th. And until then, thank you again, everyone, and we look forward to having you next time. Thank you so much.